Hey everyone, hope all of you guys are well and welcome to our respiratory examination chapter. So we're going to do this chapter a little bit differently and I'll tell you why in a second. Initially, I'll just be having a chat about a very basic, kind of a formal respiratory examination. That'll be one of those caseless discussions. We're not discussing it in the context of any case. We just want to kind of review what Tally O'Connor does in the respiratory examination. And the reason that I do this is we had only one case in the respiratory examination up to 2023 that you had to do a very basic respiratory examination. But in 2023, they got a little bit interested in this topic and we saw two new cases that kind of were in a different context. So that regular chronic shortness of breath and cough case suddenly changed to a kind of a traumatic case, the guy who's had a fall, blunt trauma or a stab wound or has a rib fracture, and then you have to do a respiratory examination. Because of the difference in the context, we'll just have a chat about respiratory examination first. Talking about the basics, I'll explain about the steps, how you do it in this video. And if you just grab a piece of paper and write down like a list of things that I want you to do in this case, that'll be all good. It'll just make our discussions into our specific cases a little bit faster. What are the pitfalls of this examination? This examination is one of those difficult examination that have a super high failure rate. I'll say after abdominal examination, these guys have a very, very high failure rate. There is a few specific reasons for this. Time management is extremely challenging in this one. Respiratory examination has an inspection, has a palpation, has a percussion, has auscultation, and has a vocal resonance itself. So for those of you who might have studied for the online exam, for that, for example, shortness of breath case that we did a CVS with the respiratory exam, we did the liver dullness, we did a liver examination, we did a lower limb examination, and so on. That is not going to happen in the face-to-face exam. You already know that you're going to run out of time. And again, it is a respiratory examination. If you run out of time in the middle of auscultation and vocal resonance is not there, you haven't done a respiratory examination for me to pass you. So you want to be a little bit careful with this. The second point that for a long time we used to fail this case so well, I really don't know which tutor or which course told you this, but there is a very stupid advice that you have to do the examination on the back. That the respiratory examination happens on the back. Now we're going to talk about this completely, and that is the most stupidest piece of advice. Even without me talking, just go open up your Tally O'Connor book, see where he's doing percussion, see where he's doing auscultation. He's doing it on the front. So please, if you see that point, it's the most stupidest point that you can get. For logical reasons, I tell you why we don't do that, and we'll make decisions about if we want to examine the front or the back in the respiratory examination. And I'll say the last pitfall was the new cases that kind of appeared in 2023. This was early 2023. Both of the new cases happened in March 2023. I feel the AMC for a second thought that they can start mixing up online and face-to-face exam cases. So one of the cases of the online exam slipped to the face-to-face exam, but it was a disaster and it didn't go too well. The experience, at least for me, wasn't nice, and I'm sure they were thinking about the same thing. But I just want to give you a heads up, guys. If you get new cases in the exam, your job is to just stick to your structure. Even in March 2023, when we got the traumatic case for the first time, all the people who had worked with me, all the people who didn't panic, because yes, it was not the chronic shortness of breath, it was a traumatic case with a shortness of breath. They did not panic. They did a respiratory examination completely. They passed. Yeah. So these are the main pitfalls that we want to kind of discuss before we go into cases. So we're going to start with our wipe as usual. In terms of wipe, you want to make it as simple, as fast as you can, because this is a case that I'm under time pressure. This is not the case that I'll get stuck in the exposure or the explanation and stuff. You want to keep things simple. So, hi, my name is Amir, and I'll be examining you today. Yeah. For this examination, I don't want you to explain all of your steps. Explain your few of the key steps and in layman terms. So for this examination, James, I'll be taking a look at your chest. I'll be feeling your chest. I'll be gently tapping. And I'll be listening to your breathing sounds. Done. Very quickly. I will require proper exposure. So I'll need exposure to the entire chest. For the position, I need you to be sitting. The patient is always sitting on the bed, so that's fine. And is that okay with you? Are you happy for me to proceed? And I've, as always, memorized that I don't want to forget washing my hands. So just give me a second, go wash your hand, start your examination. So please be careful. A very fast wipe that you want to do in this case. I don't want you to explain vocal resonance and everything else that you do with the hands and the other things. Look at your chest. I'm feeling your chest, gently tapping, listening to your breathing sounds with my stethoscope. I just need proper exposure. You don't need to explain any further. I need you to be sitting. Is that fine with you? We are moving on. Now, we start with general appearance, and we want to think about in all of the respiratory examinations, what are a few nice general appearance features. So the way that we're kind of doing this examination together is, and as I'm doing the basics, I'll tell you the nice peripheral signs, the ones that most of your cases will kind of attract those peripheral signs. And then I'll tell you the other peripheral signs that Talia O'Connor mentions, but I will mention that for the face-to-face exam, it might be a little bit too much. So I just want you to keep that in mind, that the nice ones are the ones that I want you to write in red. The nice ones are the ones that I want you to remember. In terms of the other ones, I wouldn't panic too much. General appearance, number one, respiratory distress and cyanosis, super important. If you have any case of respiratory examination, shortness of breath, cough, traumatic, stab wound, whatever, you are doing respiratory distress and cyanosis first. I don't need you to kind of necessarily explain the features of respiratory distress, but if you just want to remember what are the features of respiratory distress, again, a few nice ones that you can mention: accessory muscle use. We're going to look for tracheal tug later on, and you're looking at the patient on a general appearance. You can also see if there's any contraction of the abdominal muscles on respiration. That is a feature of respiratory distress. One feature of respiratory distress that I always like you to add over here and talk about, and you can see it in your acute asthma management guidelines, is talking about this point. That although it's very specific for acute asthma, there's a purpose for it. A patient who has acute dyspnea doesn't have that full breath to talk to you. When he wants to talk, he'll talk in broken words. He wouldn't give you one full sentence with one breath that I'm doing now. He'll be like, I'm feeling. So he has to kind of gasp for air between each breath, and he's unable to speak a full sentence. So one specific one that again is a nice general appearance finding to me is the patient is speaking in full sentences. You might tell me, like, how do I check that? You have already talked to your patient when you went in. Hi, my name is Amir. What's your name? Gary. Gary, I'm doing this and blah, blah, blah. So you have kind of talked to the patient, and you just mentioned that the patient is talking normally and he can talk a full sentence. That is a feature of respiratory distress and a patient who is in kind of respiratory distress. What are the other features that Talia O'Connor mentions that usually don't come handy in the exam? He mentions like assess the voice, so comment on the voice, assess the cough if the patient is coughing, look at the character of the cough, if it's dry, chesty, if there's any audible noisy breathing like wheezing or stridor, audible noisy breathing. That I wouldn't say it's always relevant to all of your cases. And he mentions that if you're in a hospital, if your patient is on an oxygen mask, you know he needs oxygen because his saturation is low. If you have any inhalers or puffers beside him and any sputum mark. So you can see AMC has never done this with us. And I really doubt they will do, because I don't find that a very, critical examination point. Oh, the patient has a mask. Good. You can see he has a mask. But these two are the key ones that I want you to always do. So I cannot see any features of respiratory distress. I cannot see cyanosis. My patient is speaking a full sentence, and we're good to move on. So going to our next step now. So we've already seen this. We've already seen the mask and the inhalers, different type of inhalers. Respiratory examination is special. I'm sure all of you guys will appreciate about the importance of respiratory rate and saturation of oxygen in a respiratory examination. It's essentially like your pulse rate and your blood pressure in the CVS examination. You remember how important the blood pressure and pulse rate was in CVS examination? When you get to a respiratory examination, you want to check respiratory rate and saturation. I like to check it here after vital signs. The reason is all of you guys are going to get overwhelmed when you get to your respiratory examination and you're doing auscultation, the percussion and everything, and you're running out of time. But the thing that you want to remember, it is just a mention in the face-to-face exam. So as you're doing a running commentary, you tell the examiner that I'd also like to check the saturation of oxygen and respiratory rate, move on. move on. They have never given us a pulse oximeter, so you never check saturation of oxygen. They have never given us a timer in this case. Even if they left a timer, I will just emphasize that, mention it, move on. You already are running out of time. So examiner on general appearance, I'm looking at the patient. I cannot see any respiratory distress. There is no cyanosis. And I would like to check his respiratory rate and saturation of oxygen later on. Let's move on, get to the hands. So it's just a simple mention. You're mentioning it and ticking off the box and moving on. Now we want to talk about the hands. The hands have a few things that are very important, and I want you to memorize those as the nice peripheral signs, and then I want you to memorize the rest of them. So clubbing is a good one. Clubbing is a nice one. You ask the patient, so James, can you just hold your fingers similar to me or copy my movements and hold your fingers like this? Examiner, I cannot see any clubbing. So the second important finding, nice one, is pulmonary osteoarthropathy. So this usually happens in your chronic lung condition, like interstitial lung disease. It's kind of an arthropathy that happens in the fingers, so you get a little bit of deformity, a little bit of arthritis. At the same time, many of them do also get clubbing. So clubbing kind of comes in the context of these two. So the first thing that I look at the fingers, I cannot see any clubbing, and there is no pulmonary osteoarthropathy. The second and third good features that I want you to remember, especially for the old regular case of AMC. Number one is wasting of the small muscles of the hand, wasting of the small muscles of the hand, and checking flapping tremor. So remember, for flapping tremor, you want to ask the patient to extend the wrist. You want to ask them to spread their fingers. Wait for 1 or 2 seconds, and you're looking for the tremor. If you can't see it, you just skip it and move on. So I'll say like the key things for me are 1, 2, and 3. But the other important things for you is peripheral cyanosis. So we have already mentioned cyanosis on general appearance, but looking at the fingers and the nails, you're looking for peripheral cyanosis. If you want to mention nicotine stains or tar stains, you can. Again, smoking for lung cancer. These are the few things that are important for you. But let's get to the face. One nice finding that I want you to remember, and those of you who've already done my medicine workshops, we've already talked about this, that AMC loves Pancoast tumor in the lung. There is one case that we'll talk about later on, not in the respiratory cluster because it's kind of a neurological examination, but Pancoast tumor because it kind of affects the nerves and the nervous system that kind of you have in your neck, kind of gives you the famous Horner syndrome. What is Horner syndrome? So you look at the face of your patient and you mention to your examiner that I cannot see any features of Horner syndrome, but the things that you're essentially looking for is meiosis. So if you compare this to this, you can see the meiosis, and you're also looking for ptosis and also anhidrosis. So anhidrosis cannot be seen. So this is only something that I mentioned for the face-to-face exam, that if I see a Horner syndrome examiner, I'm checking for ptosis and meiosis, and there is no Horner syndrome in this patient. So essentially, you're looking at the package of the eye. I wouldn't mention anhidrosis because anhidrosis usually needs a powder test. So you put a little bit of powder on the forehead. The normal side gets moist because you're sweating. The other side stays dry. So this patient also doesn't have Horner syndrome. Now, an important discussion that we have to do together is the ENT system. When you look at references like Tally O'Connor talks about the ENT system when he's doing the respiratory examination. And it kind of makes sense because when you tell me I want to do a respiratory examination, that means you're doing a respiratory tract examination that starts from the mouth, runs down to your lungs. But in AMC, we do not do that, especially in your face-to-face exams. Again, another emphasis that we have a time management problem in this case. I don't need a nose examination. I don't want you to do a sinus examination. I don't want you to do anything where we are skipping ENT examination on purpose, and you do have a separate ENT examination. So we're going to do our ENT examination later on. You have a totally separate case. We're going to talk about it there. Remember, the fact that we talk about a respiratory examination, our focus is the lungs, the trachea and the lungs, if you want to mention the main airway and the lungs. We're not doing our upper respiratory tract examination. The only last thing that you can do in the face, so number one, nice, was Horner syndrome. Number two will be just ask the patient to open your mouth, look at the tongue, and just mention there is no central cyanosis. And you obviously, don't expect the patient in the exam to have central cyanosis because he's a normal guy. So we've been rushing, and the sooner you get to this part, the better, because key points in the neck start here. So in the neck of your respiratory examination, you have a super big key point, and that is your trachea. It needs to be checked. No matter what your case is, I need you to check the trachea. And sometimes without knowing it, you are ticking off key points. In the trachea, in the face-to-face exam, you just look at the neck. So you just tell the patient, can you look up for me just to look at his neck? Examiner, on inspection, there is no tracheal tug. Only on inspection. I don't want you to proceed to palpation of the tracheal tug. If you don't see any tracheal tug on inspection, you don't need to palpate anything. We're skipping that. But the second most important thing is checking the tracheal position. And this needs an accurate technique. So hopefully after this, you will go check your tracker position on your partner or whoever you have at home, just to get a little bit familiar with this. So inspecting about on tracheal tug. So tracheal tug is that downward movement or depression that you see in the neck on inspiration. Again, another feature of respiratory distress. When the guy's gasping for air, you're going to see a very severe depression or downward movement just under the trachea, and this is what we call a tracheal tug. So essentially, by just inspecting it, there is no tracheal tug. But getting to trachea position. The way that Tally O'Connor mentions, I want you to check tracker position. And again, please, I don't care whatever YouTube video you see that they do it with 3 fingers, leave the middle finger on the tracker. We're not following YouTube for our exams. This is Tally O'Connor's photo. This is his old book, new book. All of them, he's doing it with 2 fingers. Tally O'Connor tells you that you need to do it with your 4 fingers. By 4 fingers, he means the second and third finger. He tells you that if you imagine this is your suprasternal notch, put your 4 fingers, your second and third finger on this suprasternal notch, push upwards and inwards or backwards towards the back of the patient. So I usually ask you to do it on yourself. Place your second and third finger on the suprasternal notch. Now start moving up, but at the same time, press it towards your back. Once you do that, you'll be able to feel the trachea between your fingers, and you're just checking if the trachea is midline or deviated. This is how you check the trachea position. Again, 4 fingers, you start from the suprasternal notch. You're essentially pushing up and backwards. You don't need to explain the process to the examiner. You just need to do it in an accurate way. You just need to do it in an accurate way. And be careful not to be harsh, because this is a little bit uncomfortable. If you do it on yourself and press a little bit hard, you're going to feel how uncomfortable it is. The poor guy in the face-to-face exam, if you make it a painful process for him, he will not stay quiet. So be ready for that. You want to do it in an accurate way, show that you're doing it properly, but you don't want to go too harsh in a way that now I want to feel the entire trachea between my 2 fingers. So as long as you feel the trachea slightly, that's what you need to do over here. But finally, let's get to our chest examination. Now, here we want to talk about the stupid point. Mr. Family Guy tells you that I want you to do the respiratory examination on the back. In the face-to-face exam, do it on the back. Stupid advice. Why is this the most stupidest advice that you can get? Let's look at anatomy. So you do have 2 lobes in your left lung. You have 3 lobes in your right lung. If you look at the anatomical location of your middle lobe on the right side from the sides, your middle lobe is kind of opening towards the front. So question is, if you are auscultating the back and you do have a right middle lobe pneumonia, is there any guarantee that you're going to hear the added sounds that you expect in the middle lobe? And the answer is quite obvious, no. Yeah. So whoever tells you that we are doing respiratory examination on the back, you tell them no. Now we're going to look at Tally O'Connor. This is not something that I'm, producing from myself. We're going to look at references. And I had such a tough job making people change the way they do respiratory examination back in 2022 and 2023. But most of the people who did it in the proper way passed. So I want you to please do it in a proper way. We start with inspection. What are the few things that are important for you on inspection? You can mention chest wall deformities, the same chest wall deformities that we talked about in the cardiovascular examination. So you can talk about pectus carinatum, that is this guy, pectus excavatum is this guy. But maybe the one that will be a little bit more important for me in the face-to-face exam is the barrel chest. So examiner on inspection, I cannot see any barrel chest. There is no pectus excavatum, pectus carinatum. I want to keep it specific. You can also mention scars. So scars are also important, similar to CVS examination for you. We do have this Harrison sulcus that is a very rare finding nowadays. It's a depression that happens in the lower part of your chest. On the inside, this is where your diaphragm is connecting to your chest wall. This usually happens in patients who have had chronic cough and they haven't seen the doctor for a long time. Usually in children who have asthma, they don't see the doctor for 10 years. And that's what you kind of see on the chest. Nowadays, we don't see Harrison sulcus that easily anymore. But moving forward, if I want to make the most important key point over here is you are looking at chest movement. So let's look at the theory. What does Talio O'Connor tells you? Talio O'Connor tells you that for the upper lobe and the lower lobe, the inspection happens differently for chest movements. For the upper lobe, he tells you that I want you to look from above at the level of the clavicles, at the level of the clavicles. And remember, one key thing in respiratory examination is you are always comparing the left and right. There is no normal set of percussion, normal breathing sounds that you expect. You are always comparing the left, the right at the same level. And that's a concept that gets repeated over and over again in respiratory examination. So for the upper lobes, like you can see in this photo, you look from above, look at the level of the clavicle, you're looking for symmetrical movement. So you tell the examiner that examiner on chest movement, I want to inspect, on inspection, I want to inspect for chest movements. You go behind the patient, you look from above, and you mention that I can see symmetrical movements of the upper lobe, of the upper lobe. And then for the lower lobe, you just look at the back. You look at the back, you ask the patient, take a deep breath in and out for me. I can see symmetrical movements of the lower lobe. To tell you a few problems that arise over here, so usually you do know that your examination beds are usually a little bit elevated, a little bit higher than a normal bed. Yeah, the height is a little bit higher than the average bed that you have. Um, Imagine, and most of these cases happen in a man, and all of you know why, because you're doing a respiratory exam on the chest. Obviously, it's easier to give you a male role player. The problem that arises over here is I need you to inspect the upper lobe from above and also from behind. I get this complaint a lot from girls, usually. That, oh, I went in, it was a huge, tall Aussie guy sitting there, and I couldn't even, reach to look at him from above. Look, guys, do it as a running commentary. And it was interesting that in one of the face-to-face exams in 2023, for the first time, the examiner asked people when you got to chest movements and people went like, inspecting the chest for chest movements, the examiner told them like, how do you do that? How do you do inspect for chest movements? So even if you're not able to do that, you will make a running commentary. So let's practice together. First problem is you go into the room and you see the guy sitting at the middle of the bed. Obviously, this is a little bit hard to kind of bend back if you are a little bit short and a little bit small to see the back. You can ask the patient, like, John, can I ask you to sit on the edge of the bed for me, please? And the patient usually doesn't refuse that. He'll kind of get up, sit on the edge of the bed. This will give you a little bit of space to stand over here and do your inspection. Yeah. Now, let's say like the guy is so tall, I'm so small that I can't really inspect it from above. How do you do this? So, James, can I just get you to sit on the edge of the bed for me? Examiner on inspection, I want to check the chest movements. For the upper lobes, I can't see it, but I want to look from above at the level of the clavicles. You try to pretend you're doing that, and I have symmetrical movements of the upper lobe. You look at the back, that I'm sure everyone will be able to do that. I can see symmetrical movements of the lower lobe. That's your running commentary. So please, don't make that an excuse that, oh my God, I want to panic at that point. I'm not able to do that. And what's going to happen? Now, let's go to palpation. And if I want to just give you a heads up, guys, what is the most important step on inspection that you should not miss? Chest movement. I don't care if you miss Harrison sulcus. I don't care if you miss chest wall deformities. I don't care if you miss scars or anything else. The most important thing, the most essential step is inspection of movements. That must happen in your inspection. Now let's get to palpation. On palpation, again, you have a critical step that needs to happen. in terms of the critical step that needs to happen, it's again palpation for chest movements. I usually get you guys getting a little bit confused about inspection of chest movement, palpation on chest movement, and usually some of you guys tend to do only one. That's why, just to make it a little bit different, let's call it chest expansion. So I want to palpate for chest expansion. This is one of the most funniest stuff that I'll show you again in the in-person class in Melbourne, that accuracy shows itself over here. The idea is that you initially do it from the back. So palpation is going to happen on the back and the front both. Yeah, inspection of your chest movements only happened on the back. Yeah, so inspection of chest movement only on the back. Palpation is happening on the back and the front. We want to start from the back. The idea is that you put your fingers, you wrap your fingers around the chest wall. You wrap your fingers around the chest wall with your thumbs meeting in the midline. So you're going to hold your thumbs like that. But the most important thing is your thumbs should be not sticking on the skin. They should be lifted off. Because the way that you kind of check the chest expansion and you're comparing the left and right together is the movements of your thumbs, how much, and if your thumbs move symmetrically. Do this at home, do this on your partner, and stick your thumbs to the skin. Ask him to take the most deepest breath that he can. The funny thing is your thumbs don't move at all. And it's really interesting that I used to see a lot of like performances that people used to do that. The thumb is not moving. Examiner chest expansion is symmetrical and equal. That is the point that I get a little bit like annoyed. I go like, okay, do I want to pass this candidate? She's telling me what she needs to tell me, but the way that she's doing it and performance and accuracy, I think I'm not going to pass her. Yeah. So remember, hands wrapped up on the side, thumbs meeting in the midline towards the spine, just on the side of the spine, lifted off the skin. You ask the patient, take a deep breath in and out. You let your thumbs move, and then you comment that examiner chest expansion is symmetrical. Now we go back to the same problem that we were talking about. Again, a big guy, tall guy sitting over here, and now you have to kind of lean back because you need a good grasp on both sides. The issue is, again, if you have a problem, you ask him, please come sit on the edge of the bed for me. Try to do your best, guys. Again, I know if you have like small arms, kind of reminded me of that little girl running and saying, I have small legs. But if you have like short arms and you're a little bit short, the guy is huge, just try to do your best. Just try to do your best to kind of reach to put both hands like this on the chest of the patient and make a comment that I can see a symmetrical movement or chest expansion in the lungs. You're essentially looking at the movements of the thumb that in an adult you do expect it to be more than 5 centimeters. But the important thing is, I think one level on the back is okay. I used to tell people to do it on 2 levels, but I realized that it's already hard to reach on the back now. If you want to do it a little bit higher, it just makes the job a little bit more challenging. But you come to the front and you repeat it on the front. How do you repeat it on the front? Again, hands wrapped up on the chest wall, thumbs meeting towards the xiphoid process over here. Thumbs are lifted off the skin. Take a deep breath for me in and out. So when a patient takes a deep breath in on inspiration in a normal patient, you see your thumbs moving away from each other and you make the comment that chest expansion is symmetrical on both sides. So that's how you kind of comment on that. It's important to talk about this sign because the old case in the exam always needed this, but no one even bothered teaching us this, the Hoover sign. Hoover sign is the same chest expansion examination that you do on the front. So look, guys, it's the same thing. The fact that you call it Hoover sign, the abnormal finding that you find in a COPD patient when you check chest expansion on the front is called the Hoover sign. So it's not like a special test that you want to do 2 things. If you have a patient that you want to check the chest expansion, so you place your hands on the sides, thumbs are lifted off, you ask him to take a deep breath in. In a normal person, you expect it to expand because your lungs are kind of inflating. with all that air that you're taking in. You need your thumbs to move away. But in a patient of COPD, because of the hyperinflation, your thumbs will move towards each other. If that happens, you call that the Hoover sign. You're never going to get a Hoover sign in the exam unless they really find a typical COPD patient who has this. Your role play is most of the time the normal person, so you're always going to have a normal symmetrical chest expansion. In terms of Hoover sign, one of your face-to-face exam cases is a 45, 50-year-old man, chronic smoker who has come to you with 6 months of cough. The case kind of speaks for itself. You're thinking about COPD and cancer. So when I do this, in that case, in the face-to-face exam, examiner chest expansion is equal on the front, and I cannot see any Hoover sign. You say it in that case because in that case, you are thinking about COPD. Now, look, guys, there are other palpation steps. I'll just list them over here, but we'll talk about the relevance once we go into the cases. You can check apex speed. We've already talked about how to check the apex speed. I'll skip the explanation. You've seen it in the cardiovascular examination. Why is apex speed important for you? In a case of hyperinflation, in a case of tension pneumothorax, obviously your apex speed can be displaced. You can palpate the ribs. In the trauma cases, obviously, in the rib fracture, that is one of your new cases, you want to do it. The way that Tally O'Connor wants you to palpate the ribs, he mentions that you want to compress the chest wall on the lateral and on the anterior posterior. So if you do have a patient who's had a trauma, imagine he's sitting like this. You want to put your hands on both sides of the chest wall, squeeze it together. If you have a, for example, rib fracture, you're going to feel tenderness, and put one hand on the back then, one hand on the sternum, and squeeze it from the front. And this is the main way that I want you to check it. And the last one is checking the lymph node examination, obviously looking in the axillary, supraclavicular and stuff, but I'll say in AMC cases, we're not going to do that. Very time consuming. Obviously, the question is percussion, auscultation, vocal resonance more important, or doing lymph nodes? We get to the percussion. Now, percussion is something that all of you guys know how to do, so I really don't need to teach you. Usually it happens with your middle finger. We prefer to do it on the middle finger because obviously the technique of doing it, the more the surface of that finger and the bulkier you have the finger tapping on that finger, it gives you a better sound. Yeah. So I wouldn't do it with my second index finger. You usually do it with your third finger. And the reason is obvious because your third finger is the most biggest one that you want to do. This is where I just remind you, in a face-to-face exam, girls, nails. If you have those beautiful, lovely nails that you have, good luck doing the percussion on this case, unless you really want to shove your nail inside your own skin and just lacerate your own skin. Please, short nails. And boys, if you play Spanish guitar, please, we need short nails over here. So it's something to remember. You never know. You might be lucky and you might get a respiratory examination. So we do it with the third finger. All of you know how to do it. Again, if you look at this one, it's quite obvious that you put your third finger on the chest, on the area that you want to do it. And with your third finger, you just start tapping. Usually on the middle phalanx is where you do it because kind of gives you the best surface to do it. In terms of where to do it and how to do it in the face-to-face exam. So imagine this is the chest. Point number one, you are doing it on the front. Why are you doing it on the front, not the back? That right middle lobe. If you do it on the front, you don't need to repeat it on the back. But the only thing that I want you to remember is how many should we do and how do we do it? I usually make a joke that it really depends on how big your role player is. If you do have a massive guy, I'll maybe do 3. If I have a smaller guy, maybe I'll do 2 to 3, depending on the size. But I think 3 is a reasonable number that I want to do. But remember, you do number 1 in the upper chest, you then go to number 2. We never go 1, 2, 3, then left lung, for example. That is an incorrect way because you want to compare this sound to the other sound. You want to do it over here, compare it to the other side. You want to do it over here, compare it on the other side. Now we get to the topic of what about the base of the lungs? For the base of the lungs, if this is on the front of the chest, so let me just bring up one of the chests that we have already looked at. Like for example, this one. So you do 1 over here. So 1, 2, 3, 4, Then you do 5 and 6. With the last one, I want you to go in the axilla because you do know that over here you do have the costal margin. Yeah, so you're not able to come down over here. You don't no longer have lungs there. You kind of go into the axilla a little bit towards the axilla and do it, and that kind of takes off the base of the lungs. So if we go back to this slide of percussion, so the last spot will be a little bit towards the axilla, and you do 7, 8. The idea is comparing it. So 1, 2, 3, 4, 5, 6, and 7, 8. As long as you check the left, check the right, it really doesn't matter if you start from the left or the right. So just do this, compare it. A good running commentary. When you want to start it, you give a heads up to your patient, James, I'll just be tapping on your chest gently. Is that okay with you? The patient says it's fine. Examiner running commentary. I am going to check percussion. You start doing what you're doing, and at the end, you tell the examiner on percussion, it is either normal or if you're looking for a specific thing, there is no dullness. There is no hyperresonance. Hyperresonance. And this is the explanation that you do on percussion. There is one step mentioned in Tally O'Connor that I want you to avoid it as much as it might sound nice and necessary in especially that COPD case, but we are not doing this step in face-to-face examination. I'll just explain it for you guys to be familiar with it. We'll discuss about why we don't want to do it. The decision is yours. In a case of COPD that you have hyperinflation, you always can check hyperinflation on percussion. The way that you do it is checking for the upper border of your liver, checking for the liver dullness. You usually expect this upper border of the liver to be on the 6 intercostal space on the right midclavicular line. But you do know that if you have a patient of COPD and the lungs are hyperinflated, they have extra air, they're going to push that liver down and you're going to find that dullness lower. The way that you do it, you need to start percussing from the midclavicular line from high above in the chest, come down, resonant, resonant, resonant until you find the dullness. Once you find the dullness, you have to come to that second intercostal space, like similar to what we kind of found in the apex feet in the cardiovascular examination. So this is the second, third, fourth, fifth, sixth. It is in the normal space. This is a lengthy process. It is a challenging process. I would preferably skip this step, guys. Based on my experience seeing you guys doing your respiratory examination, I would skip this case, even if I'm thinking that my case has COPD. I do not care. Unless I'm a super fast role player, I've practiced very well, I can deliver this in 15, 20 seconds, I'll go for it. But we're not going to do it in our structures. So just keep that in mind. And we get to the most important step, auscultation. For auscultation, again, the front or the back. Look at Tally O'Connor. He kind of talks to you. The front, definitely the front. If you do the front, you don't need to do the back because doing the front kind of auscultates for everything for you. Now, this is the point that I usually bring up, something that we started our auscultation in the CVS examination with the bell. You remember I put the bell on the mitral, then the diaphragm. When you're doing auscultation of your respiratory examination, you start with the bell. So if you want to make it a point for yourself, always remember the two main auscultations that you do in the face-to-face exam. You start with the bell, not your diaphragm. Make that something that you think about constantly, so you will remember to use your bell. With the bell, you put it on the apex. So apex is above the clavicles because you do know that part, a small part of your kind of lungs pop up that clavicle. So you kind of put it on the clavicle and a little bit above it with the bell. Examiner, now I want to do auscultation. So James, I'll just be listening to your breathing sounds. You turn it to the bell. You put it on the chest and you make a running commentary that I'm auscultating the apex. So I want you to say that as a running commentary. I am auscultating the apex with the bell that the examiner is seeing. You don't need to comment on any findings, but there is a very funny thing that happens over here, and that is the accuracy. Because you're stressed, I want to say this is something that you don't know. Because you're stressed, so the stress of the exam is there. You're crying that I'm running out of time because we've spent time on things that you shouldn't have spent. What happens is the patient is breathing like 1, 2 in, 1, 2 out in a normal breathing. You put the bell over here, 1, you go 2, you change it to the diaphragm, 3, 4, 5, 6, 7, 8. Examiner breathing sounds are normal and symmetrical and equal. There's no added sounds. Remember, Remember, on auscultation, you are listening to a full inspiration and expiration. So before you started, you tell the patient that, look, John, I want you to take a deep breath in and out, usually with your mouth being open. But to be honest, that's the least important problem that I have over here. I don't care about breathing with your mouth, give it out wherever, whatever. Just take a deep breath in and out with your mouth open. Yeah. Um, you need to auscultate a full inspiration and expiration over here, inspiration and expiration over here. And this is how it goes. Bell, 1 and 2 on the apex. You change to the diaphragm, 3 and 4, 5 and 6, 7 and 8. And then you do 2 in the axilla. So 9 and 10 mean the same axilla. Maybe I'll do it a little bit lower. You do the axial auscultation and you're all good. Regarding the numbers, again, maybe for auscultation, I will do 4. Really depends on the patient, because if you do have a smaller, medium type of guy, I may do 1 on the apex, do 2 and 3, and then go to the axilla for the base. But it really depends on how big the guy is. So either 8 spots or 10 spots. There is no set of numbers that I want you to do, but I want you to do it nice. The reason that you have to wait for a full inspiration and expiration, in case anyone is thinking that, can I just do it on inspiration? Look, guys, a good examination. So if you are a GP, if you ever call up the ambulance that you have an asthma patient, when they come to you, they ask you a very funny question that for the first time made me think. The first time that I called the ambulance for an asthma patient, you tell the paramedic that the patient has wheezing. The paramedic quickly asks you, inspiratory or expiratory? And that's for the first time that you start thinking, oh, that's a good question. I didn't even bother if the wheezing is happening on inspiration or expiration. This takes time. Yes. The question for you is, do you want to take the time? Yes. Whatever time it takes, I do not care. You need to do an accurate, nice respiratory examination. So point number 1, John, take a deep breath in and out. You go to point number 2. One more. And if you look at it, it just takes around 30 seconds. It's not a big fuss. You listen to all of your spots, you come out and you give a running commentary at the very end to your examiner. That examiner, air entry is equal and symmetrical, and there is no added sounds. This is your running commentary. So hopefully the auscultation has been clear enough, talked about the problems that happen over here. Let's get to vocal resonance. Vocal resonance is easy. Same spots. You just tell the patient that say 99. So once your auscultation has finished, you have given running commentary. So James, I'm just going to be listening to your lungs again. I want you to say 99 whenever I put my stethoscope on your chest. So point number 1, can you say 99? Again, again, again. Can you repeat it again? One more time. Yeah. And you come out of your examination, you tell your examiner vocal resonance is normal. Now, just a review for vocal resonance. You do remember that vocal resonance in a normal person, and you can try this on someone at home. When you ask them to say 99 on auscultation, it will be muffled. Increased vocal resonance means that you hear it clear. And the best example is consolidation or pneumonia. The best example is a consolidation or the pneumonia. When does vocal resonance decrease, meaning that you hear it less clear? Whenever you have pneumothorax, hemothorax, pleural effusion. Yeah, these are the situations that your vocal resonance drops. Now, having said all of this, guys, I want to ask you a question, and I want you guys to answer me on the other side. Obviously, I'm not hearing you, but having done all of this in the face-to-face exam up to this point, how much time do you think you have left? And I'm sure many of you will be thinking that, yeah, that's a good point. Like, doing the auscultation, the vocal resonance, percussion, the palpation, the inspection. I've already done a 1-minute wipe at the beginning. I did the peripheral signs. That took a little bit of time. How much time do you have left? Usually nothing. I'll reassure you, usually nothing. If you run out of time over here, smile. You've done a good job. Many people don't finish this case. If you finish your respiratory examination, I'm more than happy for you. But let's go forward and talk about the other steps that we can do. Yeah. The other few things that we'll talk about, and again, make structures for our cases. Pemberton sign is nice for the respiratory examination. We're going to talk about Pemberton's in the respiratory exam, thyroid exam. So you do know that it's a thoracic outlet obstruction. Anything that obstructs this area, like a large thyroid or a pancreas tumor. You ask the patient, elevate your arms, lift your arms, yeah, and just wait for a few seconds. In real life, you want to give them a minute or two. In the exam, if you are doing this, you give them 5 seconds. I'm sure no one wants to wait for 1 minute or 2 minutes for Pemberton to say normal or not. You just want to show off if you need to do it. That usually I tell you don't do it in the exam, and I'll tell you an old story about this Pemberton sign. A cardiovascular examination is always nice. Is always nice because your lungs and your hearts are connected to each other. Even in the CVS examination, for example, that hypertension I told you, just do a quick auscultation on the base just to say that you're looking for bibasal crypt. For CVS, we've already checked the apex speed. If we want to talk about it in theory, your JVP is important. So looking at your JVP, the only problem that arises if you want to talk about it in a respiratory examination, your patient is not at 45 degrees. And that usually creates a challenge in the exam. If you want to mention JVP in a respiratory examination, but your patient is sitting, your running commentary is examiner preferably at 45 degrees angle, I'd like to check the JVP, but the JVP is normal. And just a quick auscultation of the heart sounds. We've already done the apex speed in our palpation. That usually we tend to do that, and we'll do it in most of our cases. If you get the time, just the auscultation on the 4 areas that you've already seen in your cardiovascular examination, and you want to make it a little bit fast. I'm sure no one will get time to do abdomen to check for hepatomegaly. The only reason that I'm mentioning this is the fact that it is part of a basic respiratory exam, but we're not going to do it in our structures for the exam. It's actually hepatomegaly and feeling for the liver edge. Tally O'Connor tells you that, again, in hyperinflation, your liver was pushed down. That was why the dullness was found lower than the 6 intercostal space, and obviously the liver edge will be felt on abdominal examination. But he also says hepatomegaly for secondary metastasis of lung cancer to the liver. That does occasionally happen. And getting down to the lower limb edema is always important for you, similar to cardiovascular exam. But here you do have an extra reason. A bilateral edema, pitting edema is important for you for that famous heart failure that is secondary to lung conditions like COPD. So COPD gives you a cor pulmonale, gives you heart failure, gives you bilateral edema. But just as a reminder, you know how famous your cases of DVT, pulmonary embolism are. You usually look for a unilateral edema to just one-sided edema that gives you a vibe that, yes, we do have a DVT in this case. So this is a discussion I thought I'll do just before we go into cases, and obviously cases will happen a little bit faster now. So please remember, in a respiratory examination, in the face-to-face exam, we've done a few decisions together. We are not doing ENT examination at all. We don't have the time. We are preferably not doing the liver edge, especially on percussion, because we don't have the time. And you need to do an accurate respiratory examination. So on inspection, palpation, percussion, auscultation, vocal resonance, you need to do it in an accurate way and not run out of time for this part. I don't care if you didn't get time to do CVS, you didn't get time to do abdomen or lower limb. And reminding you of that very famous slide in AMC that we appreciate that 8 minutes is not enough time to do a full physical examination. So please do what you need to do in a respiratory examination. We're more than happy as long as you do that, you do it properly, we're happy. But I want to give you the candidate who says like, no, abdomen is important for me, CVS is important for me, lower limb is also important for me. So I'll do this very inaccurate, very fast, because I want to get to these guys. Question: what is your key area? You did your key area in a rushed way. You missed vocal resonance because you were rushing. Your auscultation was not accurate. Your palpation was not accurate. You did percussion on the back. Yeah, you did CVS, abdomen, and lower limb. Good luck. I'm going to fail you. So please keep that in mind. And having this knowledge, let's now go into the exam and talk about our famous exam cases.